aortic regurgitation, we will still continue this and we will then proceed with the conduction system of the heart. Aortic regurgitation, remember, it is an early diastolic murmur. It's an early diastolic problem and it's characterized by decrescendo murmur. Whenever there is going to be blood falling back into the ventricles come back with more force, and once they contract with more force, it can spike, it can literally increase the systolic blood pressure. And I told you there's a widening of the pulse, right? This is actually associated with hyperdynamic, the condition, the pulse, which is referred to as a hyperdynamic pulse. Right? There are other names for this.
Collapsing.
So yeah, so collapsing pulse, water hammer pulse, Corrigan pulse, and I also told
Quinky.
you pulsing nail bed. Yes, that's called as
Quinky.
Quinky pulse, right? So Quinky pulse is pulsating nail bed.
Pistol short in the femoral.
Yes, pistol short femoral pulse. Yes. In the clinical venue, the aortic regurgitation is associated with various different etiologies. One of the important things that the question may talk about, as I mentioned already, that the bicuspid aortic valve, which we studied last time. But next to bicuspid aortic valve, associated with endocarditis. When you talk about the endocarditis, remember, most common, as I told you, that mitral, aortic, and tricuspid. That's actually the order of the involvement of the valve. Even in rheumatic heart disease, we discussed, and even here, points related to infective endocarditis, so that you can integrate with the pathogens which are responsible for this. Infective endocarditis, the continuous endocardial lining, right, which is involved. We know that there are various different etiologies or different pathogens which are responsible for infective endocarditis. And among these, the first that you have to remember is acute or subacute. That's first differentiation, okay? Endocardial lining is affected, we said. I just now said this. Remember, endocardial surface or the lining is affected. And the simple thing is, it can involve more than one heart valves, right? So it can start maybe with the mitral valve and later on progress to the aortic valve involvement. But then remember, it could be either acute or subacute. Now, subacute is very commonly tested. Subacute is very commonly tested, but we have to remember these are the questions which are there in your NBME as well, right? Acute bacterial endocarditis, it is due to a highly virulent organism. What is that?
Staph aureus.
Staph aureus, highly virulent organism, and that's going to be the Staph aureus. And Staph aureus, remember, the question may talk about, this is the pathogen which is basically the causative agent in individuals that are IV drug abusers, most commonly involves which valve?
Mitral valve, tricuspid, yeah, sorry.
Remember, right-sided heart valve is involved. Right. Somebody's saying IV drug abusers, so obviously it's going to come on the right side of the heart, isn't it?
Yes, sir. I think that one. I don't know.
Right. I say highly virulent. What is that?
Can you hear me?
Yeah, I can hear you now.
Yes.
Okay.
If they are normal valves, pre-existing normal valves, Staph aureus is the most common pathogen. In step 2, you will come across the different etiologies. What is the most important and the most common risk factors associated with involvement of these different types of valves? In infective endocarditis, the question may talk about the risk factors such as congenital heart diseases are there, prosthetic valves are there, that can lead to infective endocarditis. If the patient has a prior history of infective endocarditis, individuals who are having IV catheters or IV drug abuse, as I already mentioned, the subacute variant is due to the viridin strep, very classic, very important, very commonly tested. Subacute is viridin strep. Now, viridin strep classification, what type of
beta
hemolysis, alpha,
beta hemolysis?
Beta hemolysis. Let's just do quickly.
Oh my God.
Let's just quickly do that. Let's close eyes and recall. Eyes and recall. Gram-positive organisms, remember, we have cocci, rods, and branching filaments. When I say cocci, that means I'm going to be further classifying on the basis of catalase and coagulase. So catalase positive is going to be Staph aureus, right? And catalase and coagulase positive is also
Staph aureus.
Staph aureus is coagulase as well as catalase positive. But coagulase negative staph is further divided on the basis of
novobiastin sensitivity.
So we have novobiastin sensitive and novobiastin resistant. Novobiastin resistant is
epidermiditis.
Resistant is saprophyticus.
Saprophyticus.
Yes. You can remember like this. Novobiastin, right? Sensitive. The skin is sensitive. That is epidermis. The skin, epidermis of the skin is sensitive. Saprophyticus, novobiastin resistant. Fight. Newly married couple fighting. Remember, associated with honeymoon cystitis, right? So you can remember like that. Novobiastin sensitive. It is staph epidermidis. Resistant is it resists the novobiastin, and that is saprophyticus. The next one is alpha, beta, and gamma hemolysis for the strep variants. Remember, alpha was uptokin sensitive and uptokin resistant. Beta hemolysis is complete hemolysis. Alpha was partial, beta is complete hemolysis. For that, you differentiate on the basis of, come on, answer, bacitracin. Remember bacitracin?
Bacitracin.
Yes. Aptokin is for alpha, guys. Aptokin, you can say like that. Aptokin, alpha, okay? Aptokin for alpha. Beta for bacitracin, easy to remember. Bacitracin sensitive and bacitracin resistant. In gamma hemolysis is no hemolysis. But in the beta hemolysis, there is PYR positivity we check for. That is called as pyrrolonidal amidase, PYR positive, right? And then aptokin sensitive is strep, pneumo. And aptokin resistant is...
mutants in mites.
Yes, mutants.
Viridans.
Yes, right. So this is aptokin resistant. Aptokin resistant, that is viridans, and that is the species are mutants, mitis, and sanguinus. Mutants, mitis, and sanguinus, right? So just remember these three. These are the subspecies that they can give you an example, and I can tell you there is a question on that, right? You will come across in your U World also, as well as in NBME. You will come across, especially for the strep mitis. The mitis, which is there, one of the viridin species, just remember they can give you, right, that is associated with bacterial and
Step Excel Rapid Recall.
endocarditis. Question may talk about individual went through a dental procedure, right? Went through a dental procedure and there was a pre-existing prosthetic valve. Presence of prosthetic valve increases the risk of endocarditis. By the way, guys, you also need to remember for the staph epidermidis and the other species which we were discussing about, they have some important component present which can help in attachment to these prosthetic devices. And what is that? Formation of a biofilm. So can you quickly tell me, guys, what are the different pathogens that form the biofilm? Quick. One is staph epidermidis. What else? Come on. I just mentioned the another one is viridans.
Shin.
Viridans is one, epidermidis is one. No, Shin group of organisms is Shin and Thai. That is different, okay? Right? Hemp for biofilm, okay? Hemp for biofilm. So P is for the green, I will write down, that is your brother, Pseudomonas. And then there's going to be your Haemophilus influenza, right? And E is for, I just now said, epidermidis. And then the last one is mutants, mitis, and sanguinus. These are your viridin species, isn't it? Viridin species, isn't it? So viridin species. So hemp mnemonic for formation of biofilm. On the other hand, what you were telling about the Shin, let me just write down here, Shin and Thai, that's the mnemonic I gave you guys before. That is for the specialty.
IG protease.
So one is going to be your strep pneumo, yes? Strep pneumo, Haemophilus
influenza,
Neisseria. And these three organisms, they show these properties. T is for transformation.
IgA
protease production. So
and encapsulated
organisms. So just to remember that the phenomena of transformation, the genetic phenomena of transformation, IgA proteases, and these are encapsulated organisms, right? So just remember this. And in fact, for the Haemophilus influenza, the questions that are formulated in which they talk about how it is going to protect itself from complement-mediated destruction. If you recall, I mentioned about this. There is a question on that. It hijacks one of the important factor. It hijacks factor H for Haemophilus influenza. And this factor H, which is present on our normal cells, this factor H is primarily responsible to prevent complement-mediated destruction on my normal cells, right? And that was the role of Haemophilus influenza, how it is protecting itself from complement-mediated destruction. Now, talking about the other causative agents. So I finished with acute. I mentioned about the subacute. The other causes for the infective endocarditis that you have to also remember, which is, yes, individuals having related also, that's actually the site with the help of that biofilm, it remains, it adheres and attaches to. And a quick recap, as I mentioned, for the alpha, beta, and then the gamma hemolysis, there is no hemolysis. You check for the growth on the 6.5% sodium chloride. That is going to be no growth. That is sensitive. That is Enterococcus faecalis and faecium. Enterococcus faecalis and faecium is gamma hemolytic, positive for gamma hemolytic pattern. That means no hemolysis. But negative for gamma hemolytic pattern, there is no growth on 6.5% sodium chloride. It doesn't grow. That is Streptococcus gallolyticus. So S. gallolyticus, also called as bovis, that is classically associated with underlying colorectal cancer.
Colorectal
Right.
cancer.
The question talks about an elderly individuals who is presenting with weight loss, fatigue, and blood loss that can be anemia. Remember that you might have studied about this. Right-sided bleeds and left-sided obstructs. Right. So imagine if there is a right-sided colon cancer, ascending colon most commonly associated with bleeding, and that can increase the risk of fatigue and tiredness. And left-sided causes obstruction symptoms. Right. So imagine if somebody is going for any sort of GI and GU procedures. This is another very important thing to remember. This is due to the pathogen Enterococcus species. So Enterococcus species, remember, because enteral, you can remember two common complications. The question may talk about individuals going for any sort of GI procedures. Let's say, for example, you are going for, let's say, colonoscopy or such things like that. They can increase the risk of fistula formation as well as Enterococcus species induced infective endocarditis. Fistula, remember, enteric fistula, colovesicular fistula. Colovesicular fistula, classic presentation is pneumaturia, air that can be present in foul-smelling urine. The other important organisms that you should remember are HYCVS group of organisms. So HYCVS group of organisms are Haemophilus. Can you please quickly finish it, please?
Haemophilus
aggregatibacter, right? Also called as actinobacillus, right? Actinobacillus. Next. C is for cardiobacterium. C is for cardiobacterium, right? But just remember, these are actually your gram-negative organisms, but also in the classification of culture-negative endocarditis. C is for Eikenella and C is
Kingella something.
Right. Eikenella and Kingella. So yeah, these are the Ella species. And just to remember, on the side note, C is, I will write down here itself, culture-negative, C for culture-negative endocarditis that is associated with C for Candida. Remember, Candida is also one of the very common causative agent in the patients who are placing the central line. C for central line, C for Candida. Placement of central line, Candida albicans. Now, another important species you should also remember in the Ella species, right? It is Bordetella. Right, so another Ella species that we remember. There is one more, the one which is
Bordetella.
Yes, Bordetella.
Whooping cough.
Whooping cough. Bordetella pertussis. Remember, okay, whooping cough. Can you tell me quickly about Bordetella? Something about this? Yes, pertussis. Yes, pertussis. The toxin.
Protein A.
Yeah, IG. So it does something with the height. Okay, I know, but I can't.
Try. Don't give up. Try. I'm waiting. Try.
Okay. CGMP something.
CGMP?
No. Cyclic AMP.
Excellent. Yes. Right. So endocarditis. Yeah. So exactly. That's what I wanted you to remember.
Last 19 seconds.
Huh?
Yeah, disables the GI and eyes for
yes,
CMP.
So cyclic AMP. Exactly. So cyclic AMP, right? Cyclic AMP, you can remember the mnemonic cyclic AMP, right? So these are going to be the toxins which are referred to as cholera toxin. Cholera toxin increases cyclic AMP, anthrax toxin increases cyclic AMP, and M looks like E, that is E. coli. Which E. coli? Heat labile toxin. E. coli, heat labile toxin, and the last one is the pertussis toxin. So just a simple to remember, the Bordetella pertussis toxin is different than others in a way that these three are going to be GS stimulatory, whereas the pertussis toxin is GI inhibitory. So that means when you inhibit GI, you are again increasing cyclic AMP. Recall, for the cyclic AMP, we have G protein enzyme, second messenger protein kinase. We have to remember quickly, GS or GI couple. Enzyme is what? Adenylate cyclase, and second messenger is cyclic AMP.
Cyclic
and kinase is protein kinase A. So you can remember like that. A and A and A, right? So when you stimulate, you increase cyclic AMP. When you inhibit, you're going to decrease it. The other variants, that is going to be GQ coupled receptors. Enzyme is phospholipase C, and the second messengers are IP3, diacylglycerol, and calcium. And the protein kinase is protein kinase C. So here is also your C, and C. So just remember this particular G protein pathway. Coming to the point regarding endocarditis, as I was talking about, remember the infective endocarditis, Bordetella is one of those. Coxiella burnetii. Remember, Coxiella was responsible for Q fever. Remember Q fever. Remember the individuals who are grazing those cattle and sheep, right? And amniotic fluid, milk and dairy products, Coxiella. For IV drug abusers, I gave you guys already that one is going to be my Staph aureus, isn't it?
Staph aureus.
Right. So Staph aureus is the most important agent, and the second is going to be my Pseudomonas aeruginosa, and the third one is Candida. So Candida, especially if there is going to be central line place, C for central, C for Candida albicans. right? And this is associated with endocarditis. Usually it's going to be right-sided. Pseudomonas aeruginosa, please remember diabetic patients, puncture wounds, or cystic fibrosis are the risk factors, but mainly please remember Pseudomonas diabetic patients. Next, for the endocarditis, the additional thing that we have to remember is the presentation, how it looks like. So remember the mnemonic for the endocarditis. From Jane, you can remember the mnemonic, and that is, what are the manifestations? F is for fever. Patient is having fever, right? And R is for
Rod spots.
Rod spots are in the retina. These are red retinal spots. Red retinal spots. Rod spots are on the retina. Retinal hemorrhages, right? And this reddish spots, but it does have pale center. Pale center, which is associated with hemorrhages, right? It is associated with hemorrhages. Next is O is for
Osler nodes,
Osler's
painful.
right? Osler's is ouch, painful. These are painful nodes on palms and soles, right? Osler's nodes. And then M is for murmur. As we know, the murmur is going to be first is going to be the regurgitation murmur, and then is going to be the stenosis. J is for the lesions, which are painless lesions on palms and soles. These are called as Janeway lesions. Janeway lesions are painless lesions. And A is for anemia. Which type of anemia?
Hemolytic.
Huh?
Hemolytic.
Hemolytic? Is that?
No. That is for
This is anemia of chronic disease.
Yeah,
It's a chronic disease. So in anemia of chronic disease, what we see, the problem is because there's an infection going on and there is an excess production of hepcidin. Hepcidin is a negative iron regulatory protein. Hepcidin is a negative iron regulatory protein. It locks off the iron into liver and bone marrow macrophages. It locks off the iron into liver and bone marrow macrophages. So what is very important to remember about this hepcidin, whenever the inflammation is happening and the cytokines such as interleukin 6 are increased, interleukin 6 is going to go to the liver and increases the production of a positive acute phase reactant, APR. We have different types of acute phase reactants which are increased positive and negative acute phase reactants. So here here you can remember the positive acute phase reactants which are there, right? They are like hepcidin, or many others are there which we'll discuss, like C-reactive protein and all those things. But this is going to increase hepcidin and it will decrease the availability of free iron. So that means here what will happen to my ferritin levels? Ferritin levels will increase, but the iron which is present, the serum iron, it is going to decrease. It's gonna decrease. Now remember, ferritin is inverse to transferrin, that is total iron binding capacity. In fact, hepcidin also inhibits, there's a question on that, hepcidin also inhibits one of the important transporter in the intestine. It inhibits something called as ferroportin. Recall the ferroportin was primarily responsible to transport the iron from the intestine into the bloodstream. N is for nail bed hemorrhages. N is for nail bed hemorrhages. This is very important. That is actually the splinter hemorrhages. Now, why it is happening in your U world also, you will come across this question, and that is due to embolization. This is due to embolization, right? So last is going to be embolization, right? So primarily because of this embolization, you can see septic embolization, you can see splinter hemorrhages, you can see also petechiae, right? You can see petechiae.
Step Excel Rapid Recall.
But please remember, there is a step 2 question you will come across later when you will be studying for step 2. What are the complications that can be seen in infective endocarditis? Now, one of the important complications, I want you to please remember, one, very, very high yield perivalvular abscess. Perivalvular abscess. So abscess formation that can be seen, very important, associated with the cardiac complications which we are talking about. The other complications, it could be due to weakening of the wall of the aorta, and that is an aneurysm which is secondary to infection, some mycotic aneurysm. Remember, it's not fungal, okay? Mycotic aneurysms, or very important, this is also associated with conduction abnormalities. Conduction abnormalities. In your step 2 CK, you will come across more details, but right now, at least for step 1, we need to know the last one. Remember that this is going to be the, let's say this is the aorta, and as the aorta is leaving, here is my right ventricle. Okay, so as the aorta is actually going there, we see that this area which is close to the valve, it is getting weaker and weaker. So this can lead to connection between, abnormal connection between right ventricle and aorta. And this is the fistula. This is the fistula. It is called as aortocavitary fistula. This is called as Aortocavitary fistula. From the aorta to the cavity, which cavity? Right ventricle. So what we can see, the pressure here in the aorta is usually, obviously it is very high. The blood is going to constantly actually shunt from aorta to the right ventricle, right? This is one of the very common complication tested. It's not very common, it's very common tested. Okay. And then last, one of the common question we talk about the cause of death in patients with infective endocarditis is valvular insufficiency. Valvular insufficiency happens to be the most common cause. But another complication, it can lead to embolic stroke, right? It goes to the brain and this can lead to embolic stroke. Now, embolic stroke, this is basically showering of those particular vegetations into the systemic circulation that goes to the brain, right? It can go to the brain and this can lead to abscess, right? So abscess is not just only in the periphery. We can have abscess in the cerebral. So brain abscess, it is associated with hemorrhage. All these complications in the brain, right? There are many more complications. Please remember, so splenomegaly, the splenic enlargement, that is one of the very important physical examination that can be seen in patients with infective endocarditis. Next, the other important things, these vegetations can go to the kidneys. If they go to the kidneys, we understand that kidneys, it's going to cause obstruction. This can lead to acute tubular necrosis. This can lead to acute tubular necrosis. Recall, I mentioned about this last time in the clot that can embolize in acute tubular necrosis, right? Whenever there is going to be ischemia, the most common type of necrosis, which is the coagulative type of necrosis, right? The next important complication, this could be associated with septic arthritis and vertebral osteomyelitis. The most important I want you to remember is first, perivalvular abscess, yes, conduction abnormalities, yes, aortocavitary fistula, yes, splenomegaly, and then remember the embolization, right? Embolization. These are very important points associated with infective endocarditis. So what if the patient is having no bacteria involved, and that is either a vascular or an immune phenomena, right? So patients can have, like, for example, non-bacterial thrombotic endocarditis. So when you talk about the non-bacterial endocarditis, this could be due to what? Yeah.
Clots.
This could be due to SLE, right? This could be due to cancers. The cancers, most commonly, it is going to be adenocarcinoma. So adenocarcinoma, any of those, pancreatic adenocarcinoma or prostate adenocarcinoma. Adenocarcinoma, when you talk about, is gland, and glandular secretions are mucinous. And mucin, whenever it is secreted, it will activate the coagulation cascade. Mucin can activate coagulation cascade. Now, this can actually lead to thrombosis and clot formation. This is why, if you recall, I mentioned about this, the integrations that adenocarcinoma is associated with the disseminated intravascular coagulation. I gave you a simple mnemonic for DIC. It was DIC, and that is delivery, infection, and cancers.
Cancer.
Right? Delivery, infection, and cancers. So delivery, such as abruptio placentae. The question may talk about abruptio placentae, remember? Right. So this is actually responsible to activate the clotting pathway. Like we discussed, it will be even the amniotic fluid. Right. And the infections is going to be gram-negative organisms, particularly E. coli and Neisseria. And last is the cancers. The most important is acute myeloid leukemia M3 variant, as well as adenocarcinomas. Acute myeloid leukemia M3 variant, if you might have studied about something called as myeloperoxidase. These myeloperoxidase, these are crystallizing in the form of our rods. And these our rods are associated with the DIC and shock. This can cause DIC and shock. So DIC, when you talk about what is the labs that I can see in the patients with DIC, just a quick recap, what happens to the bleeding time, what happens to the PT, and what happens to the APTT. Bleeding time is going to increase. PT increase, APTT also increase, right? So question talking about, remember, decrease in platelet count. This is going to affect both primary hemostasis, which is due to platelets, and secondary hemostasis, which is due to clotting factors. Right, clotting factors. So when we talk about the primary and secondary, both consumption of the platelets can happen and consumption of clotting factors can happen, right? Question talks about bleeding from the venipuncture site. Bleeding from VP sites. Whenever they talk about this, please keep in mind first is disseminated intravascular coagulation, DIC. Right now, here, remember the causes that we were discussing. These are non-bacterial thrombotic vegetations, right? These are called as merantic vegetations, isn't it? So merantic vegetations that can be seen, these are due to some immune-mediated etiology. There is no infectious cause, and vegetations that can deposit it are sterile vegetations, right? For SLE, it can be both sides of the valves involved. And that's why both sides of the valves involved. Please remember, SLE can lead to SLS and LSE. right? SLE can cause, LSE is Liebman-Sachs endocarditis, Liebman-Sachs endocarditis, and SLS is shrinking lung syndrome. SLE is associated with inflammation of the pleura, and it can lead to restrictive lung disease. Shrinking lung syndrome, right? So it could be also associated with other immune diseases, but most importantly, the question will be tested on SLE itself, right? It's a chronic rheumatic fever. There is already a damage to the valve. There's an increase in risk of endocarditis. Chronic rheumatic fever, increase in risk of endocarditis, right? So just keep in mind the complications that can happen. Imagine if there is a mitral regurgitation that can increase the risk of volume overload. If you recall, we studied about this, and this can lead to which heart sound? S3 heart sound. S3 heart sound. S3 is early or late diastolic. Just quick recall. Early diastolic. Remember stretching of the ventricles when they attain their maximum elastic limit. And this can also increase in risk of heart failures, isn't it?
Step Excel Rapid Recall.
Right? So there is definitely a risk for heart failure, right? Now, if the right-sided heart is involved, question talks about IV drug abuser, patients having sepsis, individuals who are having prior history, hepatitis, HIV, IV drug abusers, patients, think multiple diseases, individuals that are athletes, right? Homeless individuals and patients in shelters, right? So all these different causes which can be associated with involvement of right-sided, this can go to the lungs. So these vegetations can get embolized and go to the lungs. It can lodge into any of those particular right or left lung, doesn't matter. Whenever you talk about the diagnosis, which you will study in step 1 also and in step 2 actually, and it's very important, you need to actually conduct multiple blood cultures, samples from different sites. Very common question, right? That should do. But on the other hand, don't confuse with rheumatic fever or rheumatic heart disease. Now, rheumatic heart disease, when you talk about, this is primarily because of infectious agents such as Group A beta hemolytic streptococci, right? So Group A beta hemolytic streptococci. When I say Group A beta hemolytic, that is going to be my strep. Come on, guys. Pyogenes.
Just write it, pyogenes, yes.
Strep pyogenes, yes. Strep pyogenes, right? So strep pyogenes is one of the most important one. You should remember that is the cause, that is the etiology, that is the cause for the rheumatic fever. Now, let me just tell you, let me just text to my step 2 students. Okay, doesn't matter. Sorry about that. So Group A beta hemolytic streptococci for the rheumatic heart disease. Please remember, this is associated with the same etiology causes wise. When you talk about MAT is the common thing, okay? The order wise when you talk about is MAT, okay? So mitral and tricuspid. Actually, here we were supposed to write down the conduction system. Conduction system, I'll write down 2 in separate, no problem. Okay, right? I'll write down like this conduction system along with the autonomic reflexes, right? I will write down here, no problem. That's going to be fine because anyhow, concepts are integrated that we have to study, right? If you integrate and study, you will remember better, right? Rather than just isolated, separately studying, okay? So anyways, talking about the rheumatic heart disease, remember we have a specific criteria which is called as Jones criteria, right? So Jones criteria of rheumatic fever, if you remember, right, J is for joint problems, isn't it?
Joint pains.
For joint problems, the patient has, this going to be migratory. Polyarthritis. Poly means multiple arthritis. And
multiple
migratory
joints.
means what? Migratory means what? Imagine this is the individual, right? And here is his limbs, let's say lower extremities. This is going to be the upper extremities, okay? So, for example, if there is an involvement of one of the joints, first it resolves and then it migrates to the second joint. Then it resolves, then it migrates to the third joint. And that is multiple joints polyarthritis, but it is migratory polyarthritis, right? And then this heart is pancarditis. Remember, pancarditis, that means it involves all, that is going to be pericarditis, myocarditis, and endocarditis. One of the very important cause of death in patients with rheumatic heart disease is cause of death is myocarditis. Myocarditis. N is for nodules. These are going to be subcutaneous nodules, right? Subcutaneous nodules, very important. That's a question. Also, the findings they can give you the image, right? That are appreciated. And not to forget that the type of necrosis. Okay, right? This we will discuss about this soon, right? Integrations with the valvular involvement with necrosis, right? I told you about this in my previous discussion, right? E is what type of erythema? Please complete it.
Erythema marginatum.
Marginatum, right? Exactly. This erythema marginatum, the rash that has the margins, right? Rash plus margins. So when you talk about the erythemas, I think you guys already know about this, right? The types of erythemas. S is for synonym scoria, and I will talk about the types of erythema soon, just for a revision. But synonym scoria is a rapid coriform involuntary jerky movements that involve space in the limbs. And usually, sometimes when that condition doesn't subside, you may give the patient haloperidol, just like the chorea that is patients with Huntington's are given with. Now, as we are discussing about the types of erythema, I'll just quickly revise for you all the different types of erythemas so that you don't get confused with the types of erythema. So when you talk about the erythema, we have a different variants of erythema, right? So for example, we have
It was 5 and now it's
don't worry, I'll just write down like this. Okay. So one is erythema marginatum, another is erythema migrans, another is erythema multiforme, right? Another is erythema infectiosum. Another is erythema nodosum. And now, just don't get confused with, instead of erythema, don't confuse with ecthyma,
Oh, ecthyma.
right? Just to write down like this so that you can remember. Ecthyma gangrenosum, right? Ecthyma gangrenosum, right? Right? And don't confuse with another name, which is exanthum subitum. Terminologies such as like this are very helpful to remember. Erythema marginatum, that is for the Jones criteria of rheumatic fever. Migrans is for the Lyme disease, right? Lyme disease, Borrelia burgdorferi. Erythema multiforme, that is associated with shrimp. I will write down the mnemonics soon, right? What is shrimp? Yes?
Causative.
Causative agent. SLE. Yes. Tell me about this.
Sorry.
SLE. Sulfur drugs.
yes.
Herpes. Mycoplasma. This you will see in dermatology. P is for penicillin, and P is also for phenytoin.
Yes.
Remember, many of these particular shrimp are not all, but many are also associated with cutaneous small vessel vasculitis. Cutaneous small vessel vasculitis. Many, not all. Like for example, no mycoplasma. For that, I will give you the discussion in the mnemonic. Cutaneous small vessel vasculitis, also called as leukocytoclastic vasculitis, where the patient is having, it's a small vessel vasculitis involving lower extremity purpura, and the patient is having microvasculature, neutrophils with fragmented nucleus. Erythema infectiosum, also called as fifth disease, that is due to parvovirus B19. Parvovirus B19. Erythema nodosum, that is associated with sarcoidosis. These are basically paniculitis. These are basically non-caseating granulomas. Non-caseating granulomas can be seen with sarcoidosis, right? Gangrenosum, ecthyma gangrenosum, classically associated with gangrenous lesions seen on the chest, like in patients with Pseudomonas aeruginosa. Exanthum subitum is giving a reddish appearance, like a rose, that is Roseola infantum. Roseola infantum, the type of rash that I told you about this, that it starts on the trunk, the rash on the trunk, and then goes to the extremities. The extremities. Exanthum subitum roseola rash, that is goes on the trunk and then goes to the extremities, that is go to the hands, and that's the way for roseola, that is human herpes virus 6 and 7. HHV 6 and HHV 7.
Step Excel Rapid Recall.
Right? Next, just to remember that Jones criteria of rheumatic fever, when we talk about this, is classically due to molecular mimicry. The molecular mimicry that happens in individual who had an infection. Imagine this is the bacteria, right? The immune system is actually having a cross reaction. So what is expressed on the surface of the microbe, which is the M protein, which is expressed, which is the antigenic protein, the M protein, which is expressed. M protein is a virulence factor for this organism. Super important. What are the different types of virulence factors? You must know it, right? Among these, the M protein of group A beta streptococci, which is having a similarity with the protein on the Heart muscles.
A cardiomyocyte.
Cardiomyocytes, exactly. So this is having a similarity here as well. So now what happens, there is going to be immune mediated reaction. Imagine if there's an immune mediated response. Let's say the antibodies are generated against this and they have the affinity against this antigen. Same way, these antibodies have the affinity against the antigen present on the myocytes. And this can actually lead to cross-reactive response, which is mimicking both, because a protein that is expressed on the surface, it mimics the protein on the surface of the myocytes, and that's why it can lead to destructive lesions, right? So when you have this destructive lesions, like you see in patients with rheumatic heart disease, please remember, healing occurs with completed. Healing occurs with healing occurs with completed fibrosis. Yes, exactly, fibrosis. Now remember, this is associated with fibrinoid necrosis. Right, the type of necrosis which you will see here is what? Very, 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 very important. So imagine if this is going to be the valve. Please pay attention. This is one of your, you will come across in NBME as well, and it is there in my high yield notes as well. So imagine if this is the valve. Along the lines of the along the closure lines, there is fibrinoid necrosis. Along the lines closure, fibrinoid necrosis. Definitely, you must remember this in acute rheumatic fever, right? Just remember molecular mimicry that you can also see in the context of Guillain-Barré syndrome, GBS, which could be secondary to Campylobacter jejuni, C. jejuni, or it could be also associated with secondary to Zika virus, right? So there also you will see antibodies that cross-react. There also the protein is mimicking on the surface of the peripheral nervous system. So peripheral nervous system neurons, they are also going to express, they have the similarity in it, and that's the reason this can lead to ascending flaccid paralysis. Ascending flaccid paralysis. Very, very important. Now, what can happen in a patient with rheumatic heart disease is said, the valve that can actually get narrowed, that calcification of the mitral valve. Remember, healing occurs with fibrosis and calcification, isn't it? So fibrinoid necrosis, fibrosis, and calcification, isn't
Calcification.
it? Calcification, right? So when there is going to be calcification of the mitral valve, this would lead to stenosis. And if you recall, what would be the presentation? I told you about this, that whenever there is more severe mitral stenosis, then the valve will open early. So opening snap, early
Opening snap.
early opening snap. So please remember this integrations that there is actually early opening snap, because it's a higher pressure. This will force the valve to open earlier, right? The next important thing is that the question talks about is going to be the granulomatous giant cells formation. Please remember, for the rheumatic heart disease, the granulomas formation. This what type of granuloma it looks like. Granulomatous giant cells. Remember, this is macrophages aggregated. Okay, so this forms a giant cells. And they have a specialized type of slender wavy nucleus. What is that? Slender
wavy nucleus.
Slender, wavy, ribbon shaped, rod shaped. All these are the names that can be used for the nucleus, right? And these types of macrophages with such slender, wavy, or ribbon shaped, or rod shaped, or ovoid shaped nucleus, these are called as Anichkov cells. Anichkov cells are the macrophages, right? But the granulomas, which you see, these are called as Aschoff bodies. Aschoff bodies of rheumatic fever. Remember, this is also an example of fibrinoid necrosis. We discussed about the types. Please remember, many of the type 3 hypersensitivity reaction, fibrinoid necrosis. Overall, most common type of necrosis is coagulative type, except the brain, we see liquefactive. Pancreatitis, fat, and liquefactive necrosis. Fibrinoid necrosis can be seen with malignant hypertension. We can see with polyarteritis nodosa. We can see with many type 3 hypersensitivity reaction diseases, right? Are you guys with me?
Yes, sir.
So type 3 hypersensitivity reaction, just for the quick recall, what were the diseases? So you can integrate with fibrinoid necrosis here as well, right? So type 3 hypersensitivity reaction, what are those conditions, diseases? SLE, sharp pneumonic, serum sickness, SLE, serum sickness, hypersensitivity pneumonitis, arthrus reaction. H is also for, complete it please. Henoch-Schönlein purpura. Remember that? Non-thrombocytopenic purpura. One of the most common cause of vasculitis in children. Right? R is for rapidly progressive glomerulonephritis. P is polyarteritis nodosa and post-streptococcal glomerulonephritis. So type 3 hypersensitivity reaction conditions here, there the immune complex gets deposited. When the immune complex gets deposited, remember, this would be responsible for further immune response, which we study, such as the individual is going to have complement activation and so on, right? So please remember, fibrinoid necrosis integrations, many of the type 3 hypersensitivity reaction. Whereas the rheumatic fever, please remember, it starts with antibody. When I say antibody, it is type
Type 2.
2. So we know that type 1, type 2, type 3, and type 4, which is simple and easy. You can use any A, B, C, D mnemonic if you want to use, but it is not a mnemonic thing that you have to simply memorize this. But A is for allergic reaction. So allergic reaction, that means even the patient is having asthma, right? Asthma, allergic gastroenteritis, allergic conjunctivitis, allergic rhinitis, allergic dermatitis, any allergic, or anaphylaxis.
Anaphylactic
Very,
shock.
very important is anaphylaxis. This could be also due to rupture of hydrated cyst, very common tested. Rupture of hydrated cyst or the anaphylactic reaction that could be secondary to drugs such as penicillins, right? So penicillin allergy, anaphylactic reaction. Type 2 is B is for body, that is antibody mediated.
Antibody.
So body mediated, that is antibody mediated, is type 2 hypersensitivity, and the immune complex deposition is type 3 hypersensitivity. C is for complex, right? Type 3 hypersensitivity reaction, that is antigen antibody complex are formed, right? That I gave you the mnemonic was sharp, right? And then last is type 4 is a delayed type of hypersensitivity, right? Delayed hypersensitivity reaction is type 4. But type 2 antibody mediated, remember, there are various different examples for type 2 hypersensitivity reaction. Antibodies are responsible to simply cause functional impairment, right? So maybe they are responsible to decrease the cellular function, right? So antibodies can decrease the, decrease the cellular function. When I say cellular function, that means imagine if the patient is having an antibody that is against the postsynaptic acetylcholine receptors anti-MuSK antibody. And if you recall that I told you, that is myasthenia gravis.
And thymoma.
Yeah, it is associated with thymoma. Yes, excellent. It is associated with thymoma. So cellular is myasthenia gravis, which is a post-junctional defect. Antibodies that are actually against this post-junctional anti-MuSK antibodies, or we can also say pemphigus vulgaris. Recall, pemphigus vulgaris is actually associated with antibody against the desmosomes, isn't it? Right. So there it is against interfering with the normal cellular function. Right. And last, you can also remember there are many other myasthenia gravis or Graves' disease. In Graves' disease also, what is happening? Remember, these are stimulatory antibody against the TSH receptors, isn't it?
Step Excel Rapid Recall.
The next is, after cellular, we can have a cellular destruction. This is cellular dysfunction of the cells, right? So for example, TSH receptor stimulatory is causing dysfunction. But when you say cellular destruction,
Cytotoxic.
yes, exactly. So when you destroy now, yes, this could be associated with conditions where there is an autoimmune hemolytic anemia, right? Autoimmune hemolytic anemia, yes. So you are destroying this immune-mediated hemolytic anemias, right? Or you can have, let's say, for example, mismatched blood transfusion. Blood transfusion mismatch can be also associated with a destruction, cellular destruction variant, right? Or in SLE patients, remember the antibodies against GP2B3A, a condition called as idiopathic thrombocytopenic purpura, ITP. Right? There are many more examples which we can actually write down, not to forget even RH incompatibility. Recall in RH incompatibility or in individuals who are having parvovirus B19 mediated hemolysis in baby, which can lead to hydrops fetalis, HF. Hydrops fetalis, HF. Remember that, right? Yeah. So these are all the causes that can be associated with cellular destructive variants. The last is going to be the inflammatory variant. When you talk about the inflammation, you can think like if there is going to be an inflammatory response where the antibodies are against the cell surface. For example, like we just now discussed, rheumatic fever is a type 2 hypersensitivity reaction. But later what is happening? Immune complex is also there. We see the granuloma formation is there, isn't it? Right. But main is it starts with antibody. It starts with antibody. So inflammation is there. So that is going to be rheumatic fever. But imagine the inflammation could be due to many other causes, isn't it? Right. It could be also associated with good pastures. Now, in Goodpasture syndrome, there is an antibody against the basement membrane. Remember that. And you can see linear IgG deposits. Remember, this was also associated with involvement of lungs, kidney. It is going to be concentric RPG and glomerulonephritis, right? In the lungs, this can lead to hemoptysis, right? So basement membrane antibody, right? Mutation in the type 4 collagen, Alports. Antibody against the type 4 collagen, Good pastures, right? And then the delayed type of hypersensitivity. Remember, the delayed type of hypersensitivity is very, very easy. Why? Because this could be associated with, we know, primarily it's a T cell mediated. So T cells are playing a very important role in this. For delayed type of hypersensitivity, there are many different examples. One of the most important, and you may be tested in step 1, step 2, step 3, right? And that is too important. First, I will write down GVHD. 4 letters are there: graft versus host disease, right? Graft versus host disease, 4 letters, type 4 hypersensitivity reaction. But it is also, important to remember, contact dermatitis. Now, there are many more the diseases that we can write down. I have
yes. CD malts.
Yes, CD malts pneumonic. Yes. So in that I mentioned about chronic graft rejection. D is for dermatitis, which is contact dermatitis. M is multiple sclerosis treated with interferon beta, because T cells come into the play and they are inducing a humoral immune response where the B cells that produce immunoglobulins and they can cause the damage. And then we have conditions such as lepromentis or giant cell arteriitis or giant temporal arteriitis, right? Giant cell arteriitis, or even sarcoidosis, which is non-caseating granulomatous disease, high CD4 to CD8 ratio disease that we discussed, or tuberculin skin test. Please remember, this is also a delayed type 4 tuberculin skin test, that is delayed type 4 hypersensitivity reaction. But then there is another, like for example, if somebody is taking drugs such as carbamazepine or even lamotrigine or phenytoin, such kind of drugs, anti-epileptic medications, or even minocycline and such kind of drugs, including Vanco, this would be associated with DRESS syndrome, which is drug related. Completed. Most important is for eosinophilia and symptoms, right? So this is a drug reaction that can be seen, DRESS syndrome. DRESS syndrome, please remember, it is also type 4 hypersensitivity reaction.
Step Excel Rapid Recall.
So coming back to what we were discussing in the rheumatic fever or rheumatic heart disease, just remember these integrations. Group A beta hemolytic streptococci, the antibodies can sometimes bind to different sites, and when it binds to different sites, as I said, it can damage, right? Now here, for example, in syndrome scoria, what happens that this coriform movement, it is not just actually this chorea that you see, it is primarily because the antibodies, they target the basal ganglia. So when they target the basal ganglia, remember, this would be associated with abnormal coriform movements. So involuntary, random, irregular movements of the face, the trunk, and the extremities. And the individual is having also mood changes, highly labile mood changes, and last but not the least, they may have sometimes obsessive compulsive disorders. So these complications can be associated with rheumatic fever or rheumatic heart disease, right? What we can do as far as the investigation is concerned, there is going to be, we see that there's an elevated anti-ASO B titer, right? There's elevated anti-streptolysin or anti-DNase B titer, right? That is elevated in these patients, right? Please remember that treatment-wise or prophylaxis, we can give them penicillin beforehand. That can decrease the risk of the complications. Penicillin for prophylaxis as well as for the management. Now, group A beta hemolytic streptococci, there are actually questions in this wherein they talk about the renal complications associated. Just to keep in mind that the strep pyogenes, which is responsible for these all complications, right? Strep pyogenes, which is responsible for all these complications. Remember, this pathogen can also lead to renal complications. Which renal complications this can lead to, strep pyogenes?
Complex deposition.
Yeah, immune complex deposition, yes, but wait, this can deposit, what type of renal complication? Post-streptococcal glomerulonephritis, also post-infectious glomerulonephritis, right? This is usually days or weeks after infection. Weeks after infection. Whereas days after infection is IgA nephropathy or Burgess disease, right? So weeks after infection, post-infectious glomerulonephritis, this would be characterized by presence of what type of deposits? Epithelial deposits, subepithelial, starry sky, lumpy, bumpy appearance, right? I hope you remember these all different types of appearance, right? The next important thing is to discuss about is the conduction system of the heart and autonomic neurohumoral control, right? So conduction system of the heart, when you talk about, we know that this conduction system, basic thing first we will study, and then we will discuss about the various different, action potential related ventricles and electrical action potential. So conduction system, very simple, very easy. We have our SA node, we have our AV node, we have bundle of His, and we have fibers, okay? Bundle of His and Purkinje fibers, isn't it, right? So let's say this is going to be the SC node, this is going to be the AV node, and then we have bundle of S, and then we have Purkinje fibers. Now, please remember, when you talk about these particular, remember the SA node, it is the dominant one. SA node is dominant pacemaker. Remember, it has something called as automaticity. By in itself, it can discharge the impulses, right? AV node is the second, but between the SA and the AV node, we have internodal fibers. These internodal fibers, which are what are called Bachmann, Wenckebach, and Thorel fibers, and then we have the AV nodes. AV node, I hope you know about this. I mentioned in my videos also in the regular class. We have AV nodal delay. And this AV nodal delay is a speed hump or a speed bump. And this speed bump or a speed hump, remember, this is responsible to slow down the conduction, right? It slows down the conduction. Why it slows down the conduction? Why? Because there's a question you will come across. It increases time for filling. It increases the time for filling. So filling time is going to increase. It gives sufficient time for the filling of the heart, right? And that is actually mediated by any condition that is responsible to delay the AV nodal conduction. Imagine if I increase the speed hump or speed bump. If I increase the speed hump or speed bump size, that means there is further delay in the conduction, isn't it? Right. So that means the myocardial oxygen consumption will decrease. So what are the different ways? I just want you to remember one thing, that it's the vagus which is actually responsible to dominate it. I hope you recall, I mentioned once that if you remove your heart and if you let it beat at a high pace, remember, it is going to be significantly high. It is the vagus which is dominating, that is maintaining the heart rate lower, let's say 60 to 80 beats per minute. Right. Now, the AV node is actually the junction from where the impulses are actually traveling down. So if I'm going to change the AV nodal conduction timing, then this can delay the filling. So AV nodal delay could be associated with one. Remember, in digoxin, it can cause carotid sinus massage.
Oh, yeah.
Carotid sinus massage. Anything that can increase the vagal tone. If you remember, you will study about this in your step 2 as well. Like, for example, that somebody who has dipped in the cold water or immersion in the cold water, head immersion in the cold water, that can also increase the vagal activity. But this could be due to drugs. One of the most important drugs are beta blockers and calcium channel blockers. These medications, they can also cause AV nodal delay, right? So anything that can actually, or cholinergic activity, a cholinergic activity, increase cholinergic or decrease adrenergic activity. Understandable, adrenergic is sympathetic. When you are going to reduce the sympathetic or you are going to increase the cholinergic, either way, it can cause a delay in the conduction through the AV node, right? So AV nodal delay, just remember, this is a very common thing that is tested. Questions may talk about the medications such as digoxin, or for example, adenosine is one of those medications as well. The question talks about somebody who is taking adenosine, right? It is the drug which can actually cause hyperpolarization of the nodal cells. So nodal action potential, there's going to be hyperpolarization. So it is difficult to attain the threshold for the upstroke, the rapid upstroke in the action potentials, right? Now, these are all the causes that can cause AV nodal delay. Right? And then comes, remember, for the digoxin, the mechanism, it is super important. Remember, you cannot
Sodium,
away from this.
potassium.
Yes. So digoxin inhibits sodium potassium ATPase pump. Under normal circumstances, I told you about this, the 3 molecules of sodium are thrown out and 2 molecules of potassium are taken in. 3 molecules of sodium are thrown out and 2 molecules of potassium are taken in. That is 3:2 ratio. And this is an ATP dependent pump. Now, digoxin, what it's going to do, digoxin binds and competes with the potassium. Digoxin competes with the potassium, right? So basically, what digoxin is doing when it inhibits this particular pump, it increases the intracellular sodium concentration. And when you increase the intracellular sodium concentration, the secondary pump which is present behind, this secondary pump is responsible to bring in sodium and throw out calcium. So this is your sodium calcium NCX pump, right? This is a secondary pump, the sodium calcium exchange pump. So what happens whenever there is going to be already high amount of sodium, then indirectly you are also shutting down the sodium calcium exchange pump. So the intracellular calcium concentration is going to increase, and that will increase the contractility.
Step Excel Rapid Recall.
just remember that how digoxin is responsible to increase the contractility by increasing the calcium concentration indirectly, primarily increases the sodium concentration, depolarization. And then digoxin can also cause AV nodal delay, as I told you. When it causes AV, like giving sufficient time for the filling, that means less number of contractilities, more time in the phase of diastole, more spending the conduction that can lead to more time in the relaxation. So less myocardial oxygen consumption occur. And one of the classic complications that the question may talk about, that digoxin is associated with hyperkalemia. Digoxin can cause?
Oh yeah.
Yes. Hyperkalemia. Very, very important that if somebody... Yeah, so digoxin has a narrow therapeutic index. Digoxin has narrow therapeutic index, right? So the drugs that have narrow therapeutic index require therapeutic drug monitoring. They require what? Therapeutic drug monitoring. For example, digoxin has, first of all, narrow therapeutic index. It requires drug therapeutic monitoring. Drug therapeutic monitoring.
Warfarin.
Yeah, so what are the drugs that are having narrow therapeutic index? For example, digoxin is there, lithium is there, warfarin is there, theophylline is there, theophylline is there. Most important is theophylline, right? Or even anti-epileptic drugs are there. All these drugs, right? All these drugs are having narrow therapeutic index. They require monitoring. Now, digoxin, for example, if you give this, if the individual is given digoxin, one of the adverse effect, as I told you just now, the mechanism by which digoxin was working by inhibiting the sodium-potassium ATPase pump. Recall 3 sodium going out, 2 potassium coming in, isn't it? Now, when I'm going to block this at a higher dose, obviously the extracellular potassium concentration gradually starts rising, right? So one of the potential complication that we can remember is that digoxin can cause hyperkalemia. Digoxin can cause hyperkalemia, one complication. But then if you remember that digoxin was competing with the binding of the potassium. Now, in a normal circumstances, as I mentioned before, you have to calculate the dose appropriately before you give the individual digoxin, isn't it? Right? So before giving the digoxin to the individuals, you should be cautious to give the appropriate dosage. Competing, right? So it competes. So imagine, hypothetical example, right? There are 10 molecules of digoxin, right? And 10 molecules of potassium, 11 molecules of digoxin. So what happens is, let's say, for example, 10 will neutralize 10 and you are left off with 1 molecule of digoxin. That is sufficient for us to have a proper action. Just to remember, just a hypothetical example to study. Right now, this is something that you can understand that, as I mentioned, let's say 0.5 to 2 nanogram per deciliter, that is the dose range for digoxin, let's say. Now, imagine if the patient is having hypokalemia, hypothetically. If the patient has hypokalemia and low potassium concentration, we understand that the competition is going to be reduced. So now what happens, there are 5K, but still you give the normal dose of 11 digoxin. This time what happens, there is 1 required, but instead of 1, now you are having 6 molecules, isn't it? This is going to be causing digoxin toxicity. So hypokalemia can cause digoxin toxicity. The other thing to remember, the adverse effect of digoxin toxicity. What are the adverse effects? 1, digoxin is associated with xanthopsia. If you recall, xanthopsia is yellowing of the vision. Digoxin is also associated with GI complications. The GI complications due to increase in parasympathetic drive. Increase in parasympathetic drive, right? Digoxin can cause increase in parasympathetic drive. This can increase the GI motility, diarrhea, vomiting, nausea, all. But it can also cause various different types of heart blocks. Digoxin can cause almost all types of heart blocks. Right. The other thing to remember that when there is a digoxin toxicity, we give them digibind. Digibind is Fab fragment against the digoxin. We can give them magnesium, or first of all, very important in this case, if it is due to potassium, we can also make sure that the potassium levels are normalized, right? Sometimes even pacing is required, which is a temporary pacemaker insertion. So when you actually give the pacemaker to an individual, that, as I mentioned, right, that one of the, this is basically the, and the pacing leads are actually connected, single lead or a double lead pacemaker. Single lead or a double lead pacemaker, right? Now, the pacemaker, which is basically the pacing leads that are passing through tricuspid valve. They pass through what? Tricuspid valve. And when they pass through the tricuspid valve, we know it remains intact, right? So that can increase the risk of tricuspid regurgitation. Please remember that the pacing leads are usually connected with right ventricle, right atrium, and sometimes you also pass on the right side, and then you actually pass through and reach the atrioventricular groove.
Yes.
Atrioventricular groove, and this is the site in the middle here. That's the site you actually pace now. The left side, that's the left ventricle, right?
That's a question in your world.
Exactly. Yes, that's the question. And in fact, as I mentioned, either the right atrium or either the right ventricle, or here is my left ventricle. Please remember, atrioventricular groove, that's the site you place it. That whenever the individual is started on digoxin, you should not combine with any drug that cause hypokalemia, right? And there are certain drugs that can actually decrease the excretion or the clearance of the digoxin, right? So quinidine, verapamil, especially quinidine, verapamil, as well as amiodarone. Now, these drugs are actually going to decrease the clearance of digoxin. Even quinidine and verapamil, basically, they displace the digoxin from tissue binding site.
Yes.
Step Excel Rapid Recall.
Tissue binding sites. This is one of the important concepts you should remember, right? So quinidine and verapamil, they displace the digoxin from the tissue binding sites, and digoxin is associated with, the toxicity of digoxin is associated with any individual taking drugs that can cause
Renal failure.
renal failure. Yes, obviously you are unable to clear the drug, but even more important, you should remember that any drug that cause hypokalemia, right?
Okay.
Hypokalemia causing drugs. Hypokalemia causing drugs should not be combined with digoxin. So, for example, you can remember I told you last time that LAD should not be combined with loop diuretics. So, loop acting diuretics. What is that? Loop acting diuretics. It's a very stupid way to remember mnemonic. Loop acting diuretics should not be combined with loop diuretics. And this is a thing that you can remember. So the drugs such as lithium should not be combined, aminoglycosides should not be combined, and digoxin should not be combined. Reason being, again, one by one, we can remember lithium. Why? Because whenever we give the drug such as remember, it is not just loop diuretics but also thiazides. Because thiazides are also associated with causing hypokalemia. Okay. Now we see here, imagine this is the medullary segment of the nephron, whatever. But what we notice, imagine that this is going to be my thick ascending limb, hypothetically. This is the thick ascending limb, tall region, right? And this is the distal tubule where the thiazides work. But point is that whenever I'm going to block this particular pump, I'm going to inhibit those sodium potassium 2 chloride pumps, right? And when the sodium is lost in the urine, right? Please remember that the proximal convoluted tubule is the site for almost 65% of absorption of sodium and water. So this is the site which is responsible for tubuloglomerular feedback. So this is a feedback regulatory response depending upon the concentration of the sodium. So what it recognizes that there is a lot of sodium leaving the nephron. Maybe I should start reabsorbing and retaining it. In this particular way, what happens that lithium cheats. What it does, it tries to gain access to this particular cells and it comes back into the body. So as the lithium comes back into the body, right, that means you're not clearing the lithium. It uses the same channels as sodium channels. Lithium uses the same channels as sodium. Same way, if the thiazide diuretics you give, thiazides inhibit sodium and chloride pump. Again, sodium is lost. Lithium uses the same channels, come back into the body. That can lead to lithium completed toxicity. Now, I told you about the lithium toxicity, right? The mnemonic you can remember with lithium toxicity is lithium, right? And that is L is for
leukocytes.
L is leukocytosis. So leukocytes are increased, right? So this is basically because
that
lithium
inhibits
reduces
margination.
the margination. The drugs that are reducing margination are lithium and steroids. You remember about the margination, rolling adhesion, transmigration, chemotaxis, opsonization, and phagocytosis, right? So when you reduce the margination, that means leukocytes remain in the vascular compartment, and that can lead to leukocytosis. T is for tremors.
Tremors.
Right? H is for
Hypo and
hyperthyroidism.
hyperthyroidism.
Yes, so what you should do always monitor the
TSH.
TSH levels when the patient is on lithium. I is for increased urine, which is nephrogenic diabetes insipidus. Nephrogenic diabetes insipidus. And mothers should be careful because it can lead to downward displacement of the tricuspid, that is Epstein's anomaly. These are the complications associated with lithium. We have things to discuss. We will talk about it later. But aminoglycosides is the next one. We should remember these are ototoxic. Aminoglycosides are auto and nephrotoxic. So leucodiuretics are also ototoxic.
Furosemide, yes.
Yes, ototoxic, particularly ethacrenic acid.
Yes.
Ethacrenic E for ears, this is very ototoxic agent. And digoxin, why? Because hypokalemia causes
potassium,
right, hypokalemia causes completed hypokalemia causes digoxin toxicity. Digoxin toxicity. So just remember, it could be also with thiazide diuretics, not just specific to these drugs, but thiazides also there, or any drug that is responsible to cause hypokalemia. Now, with those other medications, I just wanted to mention that xanthopsia or yellowing of the vision, these things we should always try to integrate and remember the adverse effect of various different medications, right? So we just remember we remembered all the eye findings. For example, we have xanthopsia or cyanopia. We have retinopathy. Other adverse effects that we have to also remember is eye findings, all the eye findings pathologies, cataract, glaucoma, visual brightness, visual field defects, visual field defects. Yes, visual field defects.
Blue vision.
Yes, that not blue, that red-green color blindness. Red-green color blindness.
Huh? For sildenafil?
Yes, for sildenafil is not for retinal. Sildenafil is cyanopia. Cyanopia is with sildenafil. Xanthopsia is for digoxin. Retinopathy is for chloroquine. Cataract and glaucoma both are for steroids. Steroids can cause cataract as well as glaucoma. Visual brightness is ivabradine. Right. Visual field defects is for
Vigabatrin
and
abigatrin.
Red green color blindness is for ethambutol. Ethambutol. Red green color blindness is ethambutol. Right. Tell me quickly the mechanism of action. Digoxin we done. Sildenafil inhibits
5-HT.
PDE5.
Phosphodiesterase 5. What are the phosphodiesterase 3 inhibitors?
I know it.
Is it
Enamrinone and milrinone. Even silestazole can be there.
CA and one from anastazole.
Silestazole, right? Dipyridamole is there, but it is non-specific, right? Theophylline is non-specific phosphodiesterase. So non-specific, if you want, I can write down right now itself. Non-specific is theophylline. But other phosphodiesterase inhibitors are phosphodiesterase 4 inhibitor. 4 inhibitor is one drug that is roflumilast. This is used in COPD. Roflumilast is used in COPD patients, right? COPD patients. And then these drugs, silestazole and dipyridamole, why we were writing down separately is because these medications, especially silestazole, it is tested in the case of claudication. See, for claudication, you can remember silestazole. These drugs are also used in prevention in stroke and TIA, right? These are inhibiting the platelets. Please remember, you will come across that when you inhibit phosphodiesterase, you increase cyclic AMP. When you increase cyclic AMP, platelet activity decreases. Please remember this concept, very high yield. Platelet activity decreases, right? As the cyclic AMP inside the platelet increase, platelet activity decreases, right? And then there is one drug that is not that much important, but anagrelide. Anagrelide is also a phosphodiesterase inhibitor. That drug is used in essential thrombocythemia or cytosis, where the platelet count can go to up to 1 million, right?
Step Excel Rapid Recall.
So these conditions you should remember. Ivabradine mechanism again. By the way, chloroquine mechanism. Quick.
Conversion, inhibits the conversion of the schizo.
Heme to hemozoin conversion. So for Plasmodium, what happens? Basically, it inhibits the conversion, and heme is going to be toxic for the Plasmodia, right? Steroids have various mechanism of actions that we can list down, that is inhibiting phospholipase A2. Steroids have other mechanisms, such as they are also responsible to enhance I kappa B. In a way, they decrease nuclear factor kappa B. They are also responsible to decrease the COX-2 expression, cyclooxygenase 2. Ivabradine is IF channels. It can cause visual brightness.
Visual
It causes
brightness.
bradycardia and increase in blood pressure. So it targets IF channels. It can cause visual brightness, luminous phenomena, right? It can cause bradycardia and increase in blood pressure.
Yeah.
Increase in blood pressure. It targets this nodal action potential. We will discuss about this later on, right? And then comes vigabatrin, right? Vigabatrin is GABA transaminase inhibitor. So GABA transaminase inhibitor is vigabatrin. And vigabatrin, remember, it can, VI is for visual field defects. Visual field defect.
Yes.
And lastly, that visual field defects, somatropin antagonistic agents, which is a pegylated. Whenever you see pegylated, means long acting. So pegvisomant, right? Somatropin antagonist. So when I say somatropin, pegylated means long acting, visual field defects. Again, visual field defects, somatropin. What is somatropin? Growth hormone.
Growth hormone.
Right, growth hormone, right? Growth hormone is somatropin. If you remember, that growth hormone releasing hormone will be responsible to stimulate the pituitary gland to secrete the growth hormone that targets the liver. And from the liver, what is produced is IGF-1. And this IGF-1 targets the bones or muscles and the other tissues for the growth, isn't it? Right. So this is what? Growth hormone is somatropin. It's a trophic hormone that increases the growth. IGF-1 is called as a somatomedin. It's a mediator. Because remember, growth hormone causing the growth. It's a trophic hormone, right? But how it causes the trophism to the bones and muscle? With a mediator. And who is the mediator? The mediator is somatomedin, IGF-1.
Oh, okay.
Right. IGF-1. And then comes somatostatin, that is inhibitory. Somatostatin that inhibits everywhere. So imagine somatostatin inhibits the growth hormone, right? So it is an inhibitory hormone, but not to confuse. The last one is another soma is somatomamotropin. And that mamotropin is human placental lactogen. Yes, that is responsible for insulin resistance, HPL, right? So all these things, please remember, GABA transaminase inhibitors means what they do. They inhibit the GABA transaminase for the which is responsible to metabolize the GABA. So GABA is broken down via GABA transaminase, right, to the breakdown byproduct metabolites. And here is my GT, which is inhibited by two drugs. One is vigabatrin, another is valproate. Vigabatrin and valproate. Excellent. So that increases the CNS depression and GABA activity, isn't it? Right. And then the other ethambutol, mechanism of action of ethambutol. Quick. Arabinogalactan synthase. Yes, arabinosyl transferase or arabinogalactan synthase, right? So for the TB bacteria, right? TB bacteria, it inhibits this arabinogalactan, the mycolic acid, and in a way, ethambutol is its mechanism is going to benefit for the TB bacteria, but it is associated with adverse effect of red-green. You can remember like that when you go to the signal.
Green color.
Red-green, green signal and red signal. Remember like that? And don't confuse with blue-green, okay? Easy to remember, red signal and green signal, color blindness. All right. So very extensive, guys. We have to discuss about the action potential and pharmacology and integrations with general pharmacology, all. Right. So what we have to discuss in the next class, today it's like almost 1.5 hours. We have already covered, right? I still wanted to cover maybe like, I was thinking to take like 2-3 hours session directly so that we can cover maximum. But digoxin, let me just check it. How much time I have before I start my step 2 class. Okay, let me just take like a little more topic I will cover with you guys. So conduction system of the heart, which I mentioned with, right? Conduction system of the heart, which I mentioned. You guys are okay with this, right?
Yes.
Yes.
Yes, sir.
Yes. So the nodal and ventricular muscle action potential, I want you guys to also solve those questions in the Q book that I have sent you guys, right? This Q book, right? So in the Q book also we have the active recalls, right? So please switch off this all the active recalls and the MCQs, right? And make sure that you solve this all Q book active recalls. Moreover, at the bottom also here we have some rapid fire drills. Okay, so please make sure that your rapid fire drills are also completed. Okay, don't leave anything for tomorrow. Tomorrow never comes. Finish it now. Only today. That's it.
Step Excel Rapid Recall.
Okay. Now, the next important thing, ventricular muscle action potential. Now, if you talk about the action potential, right, we have various diagrams we can go through. But before that, I will just give you an easy diagram right now so that we can at least understand how it is going to work normally. Now we know that this is the rapid upstroke. The rapid upstroke is due to entry of the sodium, right? The positive potential that is created. But before we talk about the positive potential, which is causing this phases, right? I want you to first tell me quick, right? What type of ions which are present? Imagine this is the cell, right? Most abundant intracellular cation is intracellular cation, IC cation.
Oh, sodium. No, potassium, intracellular.
Most abundant intracellular cation, most abundant intracellular cation is
Extracellular.
intracellular
sodium.
cation is potassium. Most abundant intracellular anion is
Sodium.
sodium is anion. Ooh,
Chlorine.
No.
Oh,
Okay.
chlorine, sir.
chlorine. Oh, then what is the extracellular?
Phosphorus. Phosphate.
With phosphate.
Yes, think about it. Phosphate, right? You can remember.
Potassium.
You can remember.
Phosphate.
Remember, intracellularly we need phosphate, right? Isn't it? We need phosphate. ATP. Where do you get inorganic phosphate? Isn't it? Right. So here it's going to be phosphate. Most abundant extracellular cation is now
Sodium.
and sodium chloride is the table salt. Easy.
Yes.
Right. Now, the myocardial action potential has 5 phases, right? We will discuss about those phases. But in these phases, those ions are moving in and out. Please remember that entry of a positive charge when the cell is at, please pay attention, when the cell is at equilibrium potential, which is roughly around minus 85 millivolts. Remember, the resting membrane potential, which is the potential that is maintained across the intra and extracellular, across the cell, right? At rest is your resting membrane potential. Please remember, it is always negative. Why it is negative? Because it is allowing the positive charge to enter inside the cell. That will cause at RMP or resting membrane potential, if the positive enters, this is called as depolarization. Right? Entry, we are talking about entry of the positive charge.
Positive charge.
Right? Entry of the positive charge. But if I say at resting membrane potential, at rest, if there is going to be exit of positive charge, that is repolarization. No, you're losing this positive from inside the cell, but the cell was at rest. Remember, repolarization happens when the depolarization completes. Now you come back as repolarization. But when you are at rest, when you are having a resting membrane potential, please remember RMP is maintained by potassium equilibrium potential. It's the potassium that is responsible to maintain the resting membrane potential. But if the positive charge leaves, that means you are making it more negative. Yes or no?
Yes, sir.
This is hyperpolarization. Excellent.
Oh, yeah. Equilibrium.
That's what hyperpolarization, the example that is studied about the drug adenosine that causes hyperpolarization, that's primarily in the nodal vessel, nodal action potential. But the point is that after the entry of the positive, now after depolarization, if there is a positive charge leaving, now we say it is repolarization. Clear, everyone?
Yes.
So now the first upstroke, the rapid upstroke, is phase 0. In the phase 0, the rapid upstroke is due to entry of the sodium, and the height, the maximum that it reaches, is going to be the positive that is attaining the sodium equilibrium potential. So basically, no more sodium can enter inside the cell at the end of the phase 1. Okay, so at the end of the phase 0, I'm sorry, phase 0, rapid upstroke, sodium enters inside, and in this, up to, let's say this is going to be 0, then this is going to be positive. So as it reaches a little positive, all the way starting from the minus 85, upstroke happens, right? And then it can lead it to
potassium leaving out.
yeah, end of the phase 0, where no more sodium enters inside the cell. Then comes the phase 1. So this is going to be my phase 1. So phase 1 is characterized by, completed please, characterized by what?
Potassium,
Potassium
starts leaving.
Yes,
And
start
then-
leaving. And then is my
Plateau
phase
phase.
2. Phase 2 is plateau phase. In the plateau phase, in the phase 2, the potassium exit is balanced by
Calcium coming inside.
calcium entry. So positive entry, positive leaving, that gives a plateau phase. And at the end, here you can remember that there is gradually, you're about to end this particular phase 2 of action potential. The absolute refractory period, this ARP, which is starting with the upstroke, absolute refractory period, starting with upstroke, and then it ends after the plateau. That is absolute refractory period. So plateau is ending, but you can see there's a still downward drift after plateau, right? So this is my absolute refractory period as the plateau is about to end after the from the upstroke until there. But when I consider the complete phase, the complete phase where the conducted action potential, obviously, if you try to elicit, you cannot elicit further another action potential here, but it is a little bit longer than ARP, that is effective refractory period.
Refractory period.
Right? And relative refractory period is a relative measurement, right? In this case, you are comparing, right? You are comparing, this is the relative refractory period, RRP, which is low yield. Just wanted to mention that it is the period immediately after ARP actually, right? But it is relative measurement with another action potential, right? But just to remember that these all phases which you studied we have to mainly remember about the different electrolytes changes happening. So potassium leaves in this phase, which is going to be phase 3. This is going to be phase 3. Potassium continues to leave in the phase 3, right? And phase 4 is once this
Potassium equilibrium.
yes. So outward potassium current is phase 3, right? And this is going to be my IK current, right? Outward potassium current, which is for the repolarization, the same IK current which will be discussed, right? Which we'll be discussing in the phase 3 later on, the outward potassium current, which is in the nodal action potential as well, right? So mutation in the IK channels, it is associated with
Hyperpolarization.
diseases such as congenital long QT syndrome.
Oh yeah, QRS.
Congenital long QT syndrome is a potassium channelopathy disease which is characterized by 1, Romanov-Watt syndrome, and Jervell-Lange-Nielsen syndrome. And Jervell-Lange-Nielsen syndrome. Jervell-Lange-Nielsen syndrome. So Romanov-Watt syndrome, the mode of inheritance is autosomal dominant. Romanov-Watt, A and D, autosomal dominant. Jervell-Lange-Nielsen syndrome, there is no D in Jervell-Lange-Nielsen, so this is autosomal recessive. And this is associated with deafness, sensory neural deafness. But there is no deafness in Romanov-Watt, right? Both are associated with long QT or QT prolongation that can lead to sudden cardiac death. This is potassium channelopathy disease. Whereas we have a sodium channelopathy disease. Right? Sodium channelopathy disease is?
Brugada.
Yes, Brugada. Brugada is also mode of inheritance is?
Autosomal
dominant. Brugada is autosomal dominant, isn't it? Right? And Brugada syndrome, a sodium channelopathy disease, this condition, remember, is associated with pseudo-right bundle branch block, ST segment elevation, pseudo-right bundle branch block, ST segment elevation, more commonly seen in Asian and Mexican population, chromosome number 3, right? Asian or Mexican population associated with sudden cardiac death. That's why these individuals, they require defibrillators, right? So far, action potential is clear for everyone?
Yes, sir.
Right? No doubts about action potential.
No.
Yes. So just remember this, right? Nodal and ventricular muscle action potential. This is right now ventricular muscle action potential only. We will cover the nodal action potential in our next section. In this, I will discuss about the medications. First, we have to talk about just a last quick. We will go through different drugs which are targeting at different phases in this particular action potential, right? So please remember that the ventricular muscle action potential, right? The last phase which was there. This is your phase 4, right?
Mhm.
That is again the end where you reach the rest. That is resting membrane potential. Now you reach the rest, and I told you it is due to potassium. So for phase 4, potassium equilibrium potential. Potassium equilibrium potential.
Yeah,
Right?
sure.
Please remember the phases that you studied about this in the myocardial action potential. Remember, it has simply 5 phases: 0, 1, 2, 0, 1, 2, 3, 4. 5 phases are there. Remember, the calcium influx into the cytoplasm when it occurs during the contractile force, right, from the sarcoplasmic reticulum, this can cause contraction of the myocytes. Right. And please remember, if you recall, I mentioned about this, it is very, very important when the contraction is completed, then the calcium rushes back into the sarcoplasmic reticulum. If you remember this, right? First of all, when the calcium is released from the sarcoplasmic reticulum, it will favor more calcium exit, right? So if you recall in the action potential phases, as the calcium released from the sarcoplasmic reticulum, this will induce calcium-induced calcium release, isn't it? And then when the calcium is responsible to bind to troponin C, and this would remove the tropomyosin, myosin head binds to actin, and then we have the different phases where the power stroke happens and the calcium is detached, and we have myosin ATPase, which is responsible for utilizing the ATP, and a phosphate binding happens, and then the detachment, and calcium is actually rushing back. Calcium rushes back to sarcoplasmic reticulum, and this rushing back of the calcium to the sarcoplasmic reticulum, which is via SERCA ATPase, isn't it? That is studied in the muscle contraction, isn't it? But the point is that here we do have another important component which is called as phospholamban. Now, this phospholamban is actually present in the sarcoplasmic reticulum like a door. That's like blocking there. It's important that as there is going to be increased contractility, please remember there is constant phosphorylation of phospholamban. The phosphorylation of phospholamban, which is responsible to open this door and calcium rushes back. Remember, as there is, please pay attention to this point, this is a question, increased sympathetic drive, or patients with hyperthyroidism. Remember, there is a tachycardia. Remember that sympathetic drive, that means positive inotropic, positive chronotropic, and positive dromotropic.
Dromotropic.
Right. So positive inotropic is force of contraction, chronotropic is maintaining the rate, and dromotropism is conduction. Lusitrophy is low yield. Lusitrophism is vigorous relaxation, which is low yield. But whenever there is an increase in sympathetic drive, we know that there is going to be faster phosphorylation of phospholamban. Right? And faster entry of calcium in the sarcoplasmic reticulum. Why? Because the faster it rushes inside, faster it is available for subsequent beats. So when there is an increase in sympathetic drive, there is a rapid contractility, faster force of contraction, faster availability of calcium for the subsequent beats. You understand, guys? Everybody fine? Right? These are the points just we need to cover. And last thing that we will cover right now, and we will wrap up our discussion, inward calcium current that I mentioned about in the sarcoplasmic reticulum. It is also important to remember it coincides with which phase of the cardiac action potential? Pay attention to this. Which phase of the cardiac action potential? Remember, when there is an increased sympathetic drive, there is an increased inward calcium. Calcium inward current was during plateau phase. Right? This is very, very important. And there is an increased activity of calcium pump. That is a different thing. Of sarcoplasmic reticulum. Right? So this happens by phosphorylation of phospholamban. So more calcium is accumulated by the sarcoplasmic reticulum, and then more calcium is available for the subsequent beats. Now, let me just explain some important things. First, quickly just go through the medications and the drugs that are targeting different phases. Antiarrhythmic medications, we have to remember how they work. So all class 1 antiarrhythmics are sodium channel blockers, right? So class 1 are 1A, 1B, and 1C. 1A, 1B, and 1C.
1B and 1C.
But class 1A are sodium channel blocker and
Potassium
channel blockers. Class 1B are sodium channel blockers and potassium channel what?
Potassium openers.
And 1C are just sodium channel blockers.
Sodium channel
So this is going to be
blockers.
blocking sodium channel as well as the potassium channel.
Yes.
And this is going to be sodium channel blocker and K is getting open. And 1C is just sodium channel blockade, isn't it? So the drugs that are targeting that class 1A are, what are the drugs?
Queens,
Quinidine.
quinidine, disopramide,
Procainamide and disopyramide. Quinidine, procainamide, and disopyramide. Class 1B are
lidocaine,
mexilitine, phenytoin, right? Next, 1C is
propofin,
flecainide, and very, very
flecainide.
important, propafenone. These are the drugs. Now, class 1A antiarrhythmics, 1B antiarrhythmics, 1C. Among these, I want you to pay attention. Very important is the potassium channel blockade property, right? Just as a quick side note, I will write down class 1 antiarrhythmics. These are primarily sodium channel blocker. Class 2 antiarrhythmics are beta blockers. Class 3 antiarrhythmics are potassium channel blockers. Class 4 antiarrhythmics are calcium channel blockers. And then we have unclassified antiarrhythmics, which are like adenosine or magnesium. Clear, everybody?
Yes.
Yes,
You guys
sir.
will revise this all?
Yes.
Very easy, right?
Not that.
No, it is.
Not too easy, but doable.
Yeah, what is that?
Not too easy, but it's doable.
It's doable. Yes, that's what we want. We have to believe in ourselves that I can do it. If you consider and integrate, guys, don't just study isolated. Integrate the content. Integrate the content. Okay, connect this, connect the dots. Micro, pharmacology, immunology, right? All these segments, you must be in a position to connect it. Right? All right, guys, I will take a leave. Remaining all the questions of the Q book must be solved. Okay, guys, take care, guys. Bye-bye and good afternoon.
Bye. Thank you for today, sir.
Thank you, sir.
Yeah.